Interesting pilots. People around the country would come and ask us what we were doing because we were actually ahead of much of the country, but in fact, we were just doing some small pilots. And the summit was really focused on those of you who were anticipating using health information technology in EHRs. And so the topics and the discussions were very much focused on what to anticipate, how to prepare, how to select, sort of the getting ready for experience, not actually having the experience yet. And there was a lot of anxiety. There was a lot of anticipation, but it was anticipatory anxiety. You heard from us that this was going to be hard, it was going to be doable, we would help, others would help, but you would get through it. So it's 3 years later, and where are we today? We think that there are about 900 primary care providers who actually are eligible for the Regional Extension Center program. Hunt Blair promises that we will have a provider directory that will give us a more precise number, but that's roughly how many we think there are in the state. Over 90% of them actually are signed up to work with VITL to actually employ electronic health records, deploy electronic health records, and achieve meaningful use. That's actually the highest percentage participation of any program, any regional extension center program in the country, and it reflects the commitment that all of you and your colleagues have made to using technology effectively as part of the transformation that we're doing here in the state. Actually, over 650 providers are now using electronic health records according to the ONC, the federal definition, which means not only documentation, but doing electronic prescribing and doing quality reporting. That's over 70%, up from less than 20 in 3 years. While there are those who haven't gone through what you've gone through in the last few years who think that's not enough, we know better. That's a huge accomplishment, and you should celebrate the efforts you've done and recognize that those around you have done the same. We have a health information exchange that is now actually moving over 1 million transactions a month, which is certainly out of the pilot mode. A good chunk of those, nearly half, are actually providing clinical summaries into the Blueprint for Health. But in addition, we're moving laboratory results and orders, we're moving radiology results. This is, once again, something that still has a lot of work ahead of it. But for all of you who've worked with us and worked with your vendors and to help make this happen, congratulations. It's been a great achievement. In 2009, we were celebrating the fact that we had 300,000 electronic prescriptions that were passed in the state. And that was actually, that was pretty impressive, although we had a grant to make that number better. That was 12% of the total eligible prescriptions. And by eligible there, I mean that a lot of the Schedule II, as you know, prescriptions need to be done on paper. They can't really be done electronically without lots of extra steps. In 2011, and this number is going up significantly in 2012, there were 1.3 million electronic prescriptions, almost half of all the eligible ones. Once again, reflecting that all of you in your offices changed how you do things so that pharmacies actually got legible prescriptions. Patients showed up in those pharmacies and the prescriptions were not something that they had to bring with them. So their care was improved, the safety of their care was improved, and in making those prescriptions, as you know, you likely saw what else they'd received and had some real opportunities to improve the quality of care that they received. So there's lots of progress, and lots of progress that you should hopefully feel very pleased to have made, but there's still a lot to do. We need to expand the exchange. We need to have everybody connected beyond the primary care physicians to include all of the care system that contributes to the care of our patients. And we need to connect the patients themselves. You'll hear later on today some about the early experience with patient portals from some of the early adopters here in the state. A great step forward, a piece of meaningful use, but also a piece of just high quality care that we need to be doing more of and do better. We've just launched a secure messaging platform, VITL Direct, to make it easier for clinicians to connect with each other for referrals and other communications with a direct and secure and safe communication method. But once again, that's just launched and just a pilot, and we look forward a year from now to having that be much more broadly used and part of how you communicate with each other. I hope what you'll find as well, though, in today's agenda, that we recognize that you've progressed, that we've all, I think, moved forward. And so what we've tried to do is build workshops and talks that will help you where we are as a system today, not starting at the beginning, not anticipating the beginning, but looking at how to continue this process of improving care going forward. You'll also be hearing from each other. So you'll be hearing experiences of others who have been doing some of this work, and I hope will benefit from you as well. One point I would make, this summit is your summit. You know, we're trying to put together some of the pieces of it, but it's your summit. We need to hear from you about how successfully we've anticipated what would be beneficial. So there are going to be evaluation forms in all the breakout sessions. Please take the couple of minutes to complete them. It's how we actually plan and build the agenda for future summits. There will be an online survey for this plenary session. Please, we look forward to getting your feedback, constructive or otherwise. It's the only way we can get better. We've come a long way. There's a lot of challenging work to do, and we're also doing this in the context of a number of national programs. We're not doing this only here in Vermont. And so, you know, it's my pleasure now to introduce you to someone who's been on this journey with us at a national level. Janet Marchibroda has been helping move healthcare forward for a number of years. She was part of the early team that founded NCQA, which many of you know well is the entity that now helps you get your medical home evaluations. She was the chief healthcare officer for IBM, the founding CEO for the Electronic Health Institute. She was a major support for the Office of the National Coordinator as the high-tech program was brought online. And she's now the chair of the HIT project at a very interesting and extraordinary and unfortunately rarefied entity, the Bipartisan. That's not a term you hear much in a positive way. Bipartisan Policy Center in Washington, which is an extraordinary group of people that look at issues across a wide range of topics, including healthcare and health IT, and really try to look for common ground and common places to move forward. So she has a very broad perspective. She has a great understanding of the policy world, and she's also someone who's able to engage, despite all of the scars that I know she's received over the years in the work she's done, with a smile and a positive attitude that makes her a great advocate for all of the work that we do and that she does. Janet's a big fan of the work we do in Vermont, which obviously means she's very insightful. But today she's actually going to be talking about that national view. We talk here about the intersection of health and IT and the evolution of care transformation and health policy that's happening across the country. So she's going to give us that perspective from around the country. When she's done, Dr. Craig Jones is going to join us, and we'll have a discussion and a Q&A with all of you of the Vermont perspective and the national perspective and how they intersect. So it's a great pleasure to introduce Janet Marchibroda.
Thank you, David. It's a great pleasure to be here. You know, I think this has been my third, maybe fourth Vermont Summit. Even went to one the very early days, pre-high tech. So it's great to be here again and to be with all of you. And I have to tell you, I was telling Hunt, Steve, and David before my talk this morning, I feel like I know I'm waist deep in Vermont these past couple of weeks. I'm actually working on a case study on what you all are doing in light of our report and what's happening around the country, working with both the Bipartisan Policy Center and the National Governors Association. So I've been pouring through lots of documents and also looking forward to hearing a number of the sessions today. I think that we're at an important point in time. Think about the last time I was here, and as David mentioned, we were nowhere. It was pre-high tech. We were talking about why Health IT and electronic sharing of information was critically important to reform, delivery system and payment reform efforts, but we hadn't made much progress. And now here we are, and a number of clinicians and hospitals across the country are getting wired, adopting EHRs. That number's pretty high, over half. And then a lower number, but growing number, excuse me, are engaged in meaningful use. And so the environment has changed. And I think our next challenges, and I know something that you've been very effective at, is tackling two areas that I'm going to talk about as part of my talk. So let me get into it. Oh dear. So, okay, a little bit about the Bipartisan Policy Center. I've been there about 2 years, and what this is, it's a think tank. We're in Washington, but it's a little bit different. It was actually formed by all the former Senate Majority Leaders, Daschle, Dole, George Mitchell, Howard Baker, and it's one of the few places where we're having bipartisan discussions around healthcare right now. And what we do, actually, BPC, or Bipartisan Policy Center, had its roots in areas like energy. We've done a lot of work around deficit reduction with Pete Domenici and Alice Rivlin and the like, transportation, cybersecurity, and a health project was launched a couple of years ago. I'm part of that health project that is led by former Senate Majority Leaders Tom Daschle from South Dakota and Bill Frist, a Republican from Tennessee. And so what we do in the health project, health IT is a component. Oh, thank you. It must have been the flight. Health IT is a component, but we're also addressing workforce development issues, and we just launched a cost containment initiative in healthcare, which will be really interesting. So what do we do? Just teeing up in the Health IT initiative, let me see, with the leadership of Senator Daschle and Senator Frist, we launched a task force. I'm going to share with you today some of the findings from the task force. Actually, your work here in Vermont informed those. And the research question was, or the question was of this task force, led by the two of them and representing consumers, clinicians, hospitals, health plans, employers, states, and technology companies. What we're trying to do is, back last year, okay, we've got high tech, the money's moving out, huge investments, not only from the federal government, but importantly by our nation's hospitals and physician practices. How are we doing? And how do they stack up to what we need? You know, a year ago, there was a lot of interest. Gosh, old news for you. You know, more and more folks implementing patient-centered medical homes and what they call accountable care organizations and new models of care, CMMI getting that funding. That was moving quickly, not only from government-funded projects, but a number of health plans and large providers across the country are also implementing these new models of care. And we said, well, what do we need for those new models of care in terms of health IT, and how does that stack up with investments that we're making today? So I'm going to share a little bit about that with you today. And then also preview some of we're issuing a new report on October 3rd on one aspect of this, and I'm going to preview a few findings from that. Okay, so we talked about, so how did we approach this question? You know, a lot of folks will talk about health IT first, but as you know, and we all know, that health IT is not an end unto itself. So we really started with doing a literature review, high-performing organizations, improving quality, reducing cost, improving access. We started there. We interviewed 40 of them. One of them was Vermont, the Blueprint for Health. And we said, well, and then we looked at what are the common attributes of those organizations. And then we moved to health IT and said, in order to get there as a country or as physician offices, systems, community-based initiatives, what sort of health IT do we need? So we did that. And I'm going to give you, it's a long report. It's actually here. It's on our website under the Health Project. I'm just going to give you some highlights. And then we developed a set, pretty robust set of findings and recommendations that were released earlier this year, and I'm pleased to say a number of those recommendations are being implemented by the federal government, so we're really pleased about that. This is who we interviewed. Vermont Blueprint for Health was one of them. You know, a pretty diverse range of organizations, and this is what we found. The first and foremost is an organization-wide focus on the needs of the patient, and we learned about that from you and many other organizations. And we started out trying to explain that, but it really touches everything. It's almost a foundational element of the attributes of a high-performing organization. The second thing, of course, you know, you're not surprised, strong organizational leadership. So really knowing where you are, knowing where you want to go from a clinical perspective, measuring and getting there, seems easy, but doesn't always happen. But the other key finding, which was interesting to me, is strong clinical leadership. And you don't always see that in organizations across the country that are moving forward. But having clinicians participate in decision-making, if not leading decision-making at the very highest levels of the organization around where the organizations are going, where the issues are, what interventions do we need, how do we make this happen in our organization, was a common attribute of high performance. So this next one, and really a lot of our discussion today, is about access to information by a coordinated care team. High-performing organizations work to coordinate care across providers, settings, conditions, and time. Again, old hat to you, right? But not happening in so many parts of the country. And transitioning our healthcare system in every community across the country to the things that you're doing is really important, and we've got a long way to go. And there are a whole host of issues around that, most around culture and, of course, alignment of incentives. Timely access to care. So this was, if I were to say the common attribute across all 40, this wasn't all 40, but a majority of those who have demonstrated high performance provide multiple avenues for patients to receive timely care and consultation, similar to what you do with your community health teams, going out into the community. That's not so common across every organization in the country. And then increasingly, it's something that we're taking a look at, is telemedicine. I know it's been around a long time, but this issue, this notion of leveraging electronic tools to work with the patient at home is increasingly going to become important. And there are a whole host. We're seeing it happen, and there's a lot of innovation, and there are some policy barriers that are getting in the way of that. But also, so a thoughtful approach to addressing how that happens will be important. We're actually going to issue a report on this issue in November. Of course, emphasis on prevention, wellness. This sounds like motherhood and apple pie. But, when I look, I've done so much research on what you all are doing. It really aligns well. So emphasis on prevention, wellness, and healthy behaviors, of course, and I think e-health. And as David said, as you move with your health IT efforts in empowering patients, this is going to be important. And I think some of the incentives, stage 2, which goes into effect in October 2013 for many, will help us. I think it's going to be a heavy lift. I think, and I'll share more information about what we've heard across the country, but it's imperative, need to do it, and need to find ways to ease the transition for our nation's clinicians, hospitals, and other health systems. And then finally, of course, the whole alignment of incentives, really important, and we're pleased. We think it's inevitable. When there were lots of discussions around the Supreme Court decision and what was happening, well, you all have moved ahead, right? Far ahead, further ahead than anyway. So with that decision, there's a lot of discussion. What will happen to our delivery system reforms? All the good work that CMMI is doing, all the investment and evaluation made on these new models of care. And what we heard loud and clear across the system from our private sector, payers, employers, and provider organizations, that this train has left the station and that there will be a clear movement going there. It's only a matter of time. We also heard that. We're hearing that a lot. So, in my research on what you're doing, and when I think of where we ended up in terms of attributes of high performance, it syncs up so nicely with where you all are. And I was laughing earlier. I don't know where Hunt is, but he was with us at the Bipartisan Policy Center on Monday, and I'm going to share some results of our clinician survey in a few minutes. And we've been really working hard on, how do we get here? What are the remaining policy issues? And then he spoke, and he shared your story, and everyone just looked at him and said, that's what we want. We want that. That's the way we need to go as a country. And so anyhow, you're here, you're living here. It probably doesn't feel different to you, but what you're doing here is pretty special. It's a real model for how other folks can move forward. And so I know many people would like to learn as much as they can around what you've done and how you've made it work. So I just wanted to say that. So looking at the attributes that the Bipartisan Policy Center came up with and put in this report aligns really well with what you've done here with your patient-centered medical home and your community health teams. Ooh, and the strong integration of your health information technology infrastructure aligning with that, and then also analyzing progress. So we started at the beginning. What are the common attributes? And then what health IT do we need to get there? And it was really long. I've struggled with how to roll this up into 2 slides. So here are snippets of where we ended up. The first thing that access to information, and I'll tell you, we're going to talk about some of the gaps in our country, but access to information by all of those on the care team who support and deliver care to the patient is crucial. And I'll also tell you, in talking with many of the high-performing entities or organizations across the country, they were really struggling with this part. And I'll say it in a minute, that the lack of mobility of information across organizational lines is a huge issue and a foundational piece to getting to where we need to go as a healthcare system. And for the most part, it's happening with paper and fax and phone call, or not at all. And so the work that you're doing, that you've described between the clinical care summaries that the Health Information Exchange is providing, the registry that you've developed, the directed exchange that you're just launching are really important components to getting to that access to information. Huge issue, and actually the focus of our next big report that we're releasing on October 3rd. Clinical decision support, so having those reminders, alerts, other tools at the point of care. We're not there yet as a country. We've got a long way to go. Need to go there, and particularly in talking with many, many clinicians across the organization, across the country, this is really where the value is for them. This is what they really want and need, if well-designed, useful, and usable. This is what they want and need at the point of care. Analytics, of course, the ability to analyze data while also protecting privacy and security is a big deal. And if you think about where we were a few years ago, I was just talking about my old days at NCQA. We pretty much, in terms of electronic data, we pretty much had claims data and we did chart pulls, right? A lot, in many cases, that's still what we're doing, for the most part. And there's a lot of effort around, now that we're moving towards having electronic health records in an increasing number of physician offices and hospitals, what will that mean? And it's not simple. I know eHealth Initiative, a wonderful organization that I ran for several years in its beginnings, had a data analytics conference. And Jen had, some of the smartest folks in the room really grappling with some difficult issues. So this is part of the new frontier too. How are we going to make this happen? Virtual care, we talked about this. Many, but not all of the high-performing organizations are experiencing ways to care for the patient while the patient is still in the home. Going to be really important as all of us baby boomers, get older and older, and particularly with the way that we handle the rest of our lives, right? So this is a common attribute. And then this final one, a common attribute that and the health IT capabilities. So we talked about being patient-centered and the health IT capabilities that will help us engage consumers. You're seeing a lot of this. This was in our report that released in January. A lot of this is similar to what you're seeing in stage 2 of meaningful use. Secure messaging, ability to download information and view it. Take it with you, for goodness sakes. We want to be able to do that, right? As consumers and patients. And other things that make it easy for us. We can, with electronic tools, can do online scheduling and reminders for patients. So if those are the capabilities, then we looked, do we have many of these going on today? I've talked a little bit about this. And then what are the barriers to getting them done? And these don't look unusual. This misaligned incentives, I think we're getting there. Lack of health information exchange. Boy, as someone who launched, probably the first survey of health information exchange way back in 2001, I remembered, we were assessing where we were. We haven't gotten very far, right? We've made some progress, but there's still much. There's still more that needs to be done, and we're all analyzing that in great detail as we speak, and we'll release our report on October 3rd. The other big gap is, for the most part, across the country, clinicians, physician practices, and hospitals aren't engaging with their patients using electronic tools. There are a bunch of reasons why. Lack of awareness, fear of getting too many emails, a concern which was found to be unfounded by many folks that have done it with secure messaging. It wasn't as bad, once they did it as they thought. Concerns a little bit about liability, and some lack, I'm talking about this from the provider standpoint, what the barriers have been. On the consumer side, maybe those, some concerns, awareness, access, right? Having internet access, a lot of that is changing with everyone having mobile technology. I don't know what the percentage of Americans is, but it's pretty high. And many don't have normal phones in their houses anymore. They use cell phones. But privacy and security used to be a larger concern. It's starting to come down. I think we'll need to, from a policy standpoint, make sure we continue to have solid policies for the use of those tools. And usefulness and usability came up also from some of the survey data. The other barriers, of course, limited levels of EHR adoption. That's changing. It certainly has changed. It's congratulations on the numbers. I was taking notes while you were writing on where you are here in Vermont. Some concerns about privacy and security. And then this last one, we heard from a lot of folks, particularly providers, states, health plans, multiple federal priorities that require focus and attention. For most, not worries that we don't want to go here, more worries about there's so much coming at us at once. And there's only so much change that you can move forward at the same time. And so, this was a significant comment that we made. When we drilled down into some of the issues around quality measurement, the multiple clinical quality measurement programs out there, all slightly the same but slightly different, measured differently, dealing with, and then just the sheer volume of all the change that's happening was a barrier to some of this happening today. So I'm going to spend, because I want to leave some time, we're about quarter, I'm going to spend maybe about 5 or 10 minutes here, and then I want to share a preview of what we'll share on October 3rd. So we came up with a whole set of findings and recommendations. Again, nothing hugely new on this one. Of course, align incentives with better outcomes. Many thought that exchange would come when we paid differently for health care. And I've got some survey data that's pretty interesting that says, well, maybe that's not the barrier anymore. But aligning incentives with cost and quality outcomes. Continuing expanding pilots. This was at a point in time where there was a lot of oversight around how some of the federal money, and there still is continuing oversight on how some of the federal money is getting done. And given all the money that's moving into these programs, please, 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 on an not at the end of the evaluation, but when you've got lessons learned funded by federal funds, share them along the way so the rest of us can understand what you're doing. Really important. And I think that the federal programs are doing that much more so now. Exchange. Oh, the tough one. So of course we need a business case. One of the other recommendations that we put forward is this need. Rightly so, when you look at all of the activity that's being done around health IT. God bless them. The staff are working hard to put out rules and regulations associated with meaningful use. And when you look at how data, what data standards, what policies get put in place, that's important. But we would like to see a more holistic approach to use of data, standards for data for multiple uses. Not sure, where the authority lies. We're going to do some studying around that. I'm not sure whether it's a FACA that's just focused on meaningful use. It's probably broader. Maybe it's a public-private initiative. But we think real need. So as we're chasing those near-term, incorporating standards in our tools, incorporating, into certification to focus on meaningful use, there's a lot of other stuff out here that maybe doesn't overlap. That was another key finding. And so how do we be strategic as a country together to figure out what standards, what data needs to flow, what standards do we need for multiple purposes beyond meaningful use? We thought that we would benefit as a country on a more cohesive statement on a path forward for exchange. And we also found, and the survey results reveal this too, and it's exciting to hear your approach here in Vermont, 4 new models of care, many of these delivery system reforms. Pushing data will be helpful, but not sufficient for where we need to go in terms of getting these models of care going. So we had lots of recommendations about that. And I need to, this is more policy. Let's get into the nuts and bolts. Consumers had a whole section on what we found when we talked to hospitals and physician practices and primary care providers across the country. Little awareness of benefits of engaging consumers using electronic tools, and there are many. In terms of what it helps, efficiency in your practice, getting stuff done more quickly, along with all of the clinical benefits of that. But there needs to be more, I think, something for the REC to consider, or the many programs that are across states and local regions across the country. How will we help them get there? To understand what they need, where to go, a clear understanding of risks and benefits, and some nuts and bolts. How do I get this done in my practice or in my hospital? What do I need to be thinking about? What can I leverage? I think there's a huge need, particularly given that there is a lot view, download, and transmit by consumers as a requirement in stage 2 of meaningful use, which we're in 2012. It's going to go into effect next year in October for many providers. So this part's going to be a lift. 3, improving usefulness and usability, and then aligning incentives, of course. On the adoption side, improving clarity of some of the requirements. I've been really impressed with the progress and the tip sheets and all of the things that came out more quickly here with stage 2. There was a lot of churn around understanding what the requirements were, and then improving usability and safety, something that's I'm not going to address in this talk, but something that we're looking at carefully. Privacy and security. The biggest thing we heard here was, and I heard it with the interviews of the 40 high-performing organizations. Lack of clarity is a blocks movement. So it wasn't necessarily that we need more policies, but it was more about, well, what exactly, if I do this, am I going to be compliant with these particular rules? And that can be handled by clarifications. Written clarifications issued by HHS. So comprehensive and clear guidance is needed. Common sense security practices. Now this one, David Blumenthal, who was here last year, was it last year? 2 years ago. Don't put the password on a sticky on your laptop. Don't take, goofy stuff like that is where a majority of the issues happen. They're not scary, spooky people that are trying to hack into your system. It's just common sense stuff. And I'll tell you, and I hear it over and over again, there isn't broad awareness of that among small, medium, and even in some cases large physician practices, workers. So common sense security practices are in order. And then this other one, looking at how am I doing on time? We actually did a whole issue brief on this third finding and recommendation around needing a national strategy to improve the accuracy of patient matching. I don't know how many technical people I have in the room. Does anyone know what that means? By raise of hands. Okay. So for the other 60%, and actually in our issue brief, we lay out a scenario. We go around the healthcare system, and we don't have a national patient ID. That's actually prohibited by law. There's a little rider that gets attached that's saying the federal government, we should not have a unique ID, mandatory unique identifier. We actually didn't recommend that, but we said, we've got matching issues. We collaborated with this college, an association of CIOs of hospital systems, and they did a quick survey. It's pretty scary. 19% of hospitals surveyed, and these are like Chimes hospital members are fairly sophisticated hospital systems, right? 19% had experienced an adverse event within the last year due to a mismatch of data. So for the non-technical people, we go throughout the system, and then when I go to a hospital and they pull records even from their own systems within the health system and outside, they've got to find a way. Janet Marchibroda is not a good term because it's not a common, but if my name was Jane Garcia, Jane Rodriguez, Jane Smith, Jane Kim, there are a number of folks in the country that would have my same date of birth, some of the matching, my same name, and all the other demographics that go along with it. And so errors happen, and they're upwards of, I didn't bring the report with me, I think 26, 27%, sometimes 8%, but there's a big range. So we're saying, okay, we need a strategy Do we need a national identifier? Probably not. That's just another field. We did say, we're going to say again on October 3rd, there are voluntary ways to provide additional fields, whether it's my cell phone number or my place date or location of birth or other issues that will help. If I provided that on a voluntary basis and said, I'm okay if you use my cell phone for matching with all the other physician offices in the community, we need ways to improve the matching, particularly as data starts to flow. And we've done a lot of meetings with folks on the Hill and with Farzad a couple of days ago. They're limited in the kinds of conversations that they can have, but I think there's a very strong openness to having that conversation or that dialogue. Really important, by the way, as you get to some of these coordinated models of care. Enough. I've gone too long on that issue. And then this is the alignment piece. Need to do a better job aligning across programs. Aligning across health IT programs, aligning health IT programs with health and healthcare programs. And so how do we look at those barriers again? This is part of the case study I'm writing. How does Vermont stack up? You've actually done an amazing job. Your alignment of how your health IT investments are all aligned, the amount of communication and coordination that takes place, the fact that you're using technology not to implement technology and check the box, like many folks are, but you're actually using it to support your reform efforts. It's a foundational part of the blueprint for health. I'm looking forward to talking more about that. It's a foundational part around delivering health care, and that's really exciting. The whole EHR adoption piece, the work that you've done around offering support and implementation assistance, your continued focus on the patient. I know David said you want to spend more time in that specifically, or particularly given the amount of requirements that are coming up related to that, beyond just doing the right thing. You've got a lot of focus on policies associated with sharing information, and again, your alignment is amazing and should be a model for others to follow, actually. And that's going to be one of the key points that we're going to make in this case study. Okay, in my last couple of minutes, I just wanted to, because I want to leave about, or we're going to go into discussion. Oh, okay. So there we are, in a nutshell. What are the common attributes of high performance? What health IT is needed to get there? And then where are the gaps in our country and what do we need to do about it? So I'm going to do, on October 3rd, we're going to do a bit of a dive on the need to electronically share information across organizations. I'll tell you, this has been probably the hardest work that I've done since my time at the Bipartisan Policy Center. This is a thorny issue. It's difficult. So we've been doing a lot of discussions and we've been collecting some data to help inform where we need to go. But one of the things that we collected, we just, Doctors Helping Doctors, Transform Healthcare, which is a number of doctors working together, an organization with which I'm affiliated, conducted a survey, actually created a survey of clinicians to gain an understanding of clinician needs, clinician electronic health information sharing needs. What do they want and need to support how they deliver care? It seems so simple. It seems really simple, but you know what? There haven't been, I think I counted 1 or 2 peer-reviewed studies, and they were local. There hasn't been a lot done in this area, and particularly as we're moving there as a country, really important, and particularly given it's been so hard to develop a national strategy, or even local strategy for some, not here, but others, to get there. So we wanted to gain an understanding of clinician needs, and we wanted to expand the physician voice within this survey. It was fielded by a couple of organizations, some of which are still doing it. American EHR Partners is an organization that the American College of Physicians started. They fielded it. The ACP has about 130,000 clinician members across the country, pretty big. And then through American EHR Partners has other medical societies. AMDIS fielded it. Those are the CIOs. They're more sophisticated, larger. But American College of Surgeons and the pediatricians are fielding it now. We're going to close it on Monday. So it's going to be tight getting it into the report. And ACP is helping us with the analysis. So this is redundant. So okay. So the bottom is what you should concentrate. So we looked at 3 scenarios. When one of your patients gets discharged from a hospital, we listed a whole set of information types and said, tell us if it's not important, somewhat important, very important, essential, etc. The second scenario, when a referring clinician, refers a patient, what does the consulting clinician want? Again, these are transitions of care. And then when the consulting report comes back to the primary care clinician, what information do they want back? And they analyzed it. So what did we find? We're writing this up now. There clearly is a set of essential data types that clinicians want and need to inform decision-making in these scenarios. But do they want everything immediately? Probably not. The other thing that we learned is they want it much more quickly than folks are sending it. And then a majority prefer to have that information, only the essential information pushed to them, but the ability to query and pick up the rest. So don't overload me. Give me what I need, but give me the opportunity to go back and hunt for what I need. So I'm going to go back to that slide. So I'm not really supposed to share these, but so it's not on the website because we're going to share it later, and we're converting this into English language so policymakers can understand it. So when a patient gets discharged from the hospital, the most essential data types are the medication list, relevant lab test results, radiology and imaging results, okay, and of course the discharge summary. Those are the most essential items in that scenario. We're going to run an analysis of primary care versus specialty versus surgical specialty. There are some differences that I'm not going to go over here. When I'm not always a specialist, but when I'm a consulting clinician, what information do I want to accompany the referral? The reason for a referral, of course, but again, med list, lab test results, radiology information. And then when I get the consulting report back from the consulting clinician, what do I want? The summary of care, again, relevant lab test results, imaging, and medication list. So you'll say, so what? Of course, we knew that. Nothing big here. But when we think about prioritizing where we go, given that there's nothing happening, and when we think about implementation, and by the way, we're doing a very detailed crosswalk to stage 2 meaningful use, which will be part of the report. Meaningful use does require much of this, but not all of it in a structured format in stage 2. I'm not being very elegant in the way that I'm saying it. We're still crafting the language. We want to be really careful in the way that we craft the language. But I think stage 2, you're going to see nearly all of these capabilities in your certified EHRs with stage 2. So that's number 1, and that's really important, and it will need to be structured data, and that's important. The push and query capability is not so clear. whether that lines up exactly with stage 2, but there is a glide path that can move you through there. So that's some of the data that we're collecting. This is the part that was really interesting to me, having spent a lot of time in this area. So for those of you that have been following the exchange activity, even last year, 2 years ago, lots of surveys. What are the barriers? What are the barriers? Why isn't this happening? This is actually, we asked clinicians what the barriers were. And all the other surveys, and this is, we're going to do more work, and we actually need to do like larger population and more, but they used to say alignment of incentives was the #1 reason. Alignment of incentives, there's no business case. It's not at least in this survey, and the median practice size was 4. 75% of the respondents were 10 physicians or less in the practice. It wasn't the financial incentives. It was, I don't have the infrastructure to do this. My vendor systems aren't interoperable. The cost of setting up the interfaces. And for me, and I looked around the room, I said, guys, this is good news. These are problems we can solve. I mean, the incentives issues and the privacy issues and the thorny the policy and the legislation that needs to happen in order to address those issues, those are much harder to solve than these. And so we've got the technology and the capability out there. If we have the will, we've got an emerging business model around these new models of care, particularly here. I'm thinking we might just get there. There's some technical hurdles along the way, but they are nothing compared to some of the bigger issues. So I was excited about this, and this is probably going to be one of the biggest things that we announce. Okay, so we're going to issue a report based on those interviews again. We're going to hone in on electronic sharing of information, and then talk about remaining policy standards and market actions needed. And so that concludes, boy, a little bit early, but so do we have time for questions, or should we wait for discussion?
Why don't we have Craig come up and join us, and then we'll have questions and discussion at the same time so that everybody can participate.
Well, thank you.